A case of hemophagocytic lymphohistiocytosis, HLH. HLH is a rare syndrome caused by uncontrolled immune hyperactivation of lymphohistiocytic cells, resulting in hypercytokine, hemophagocytosis, and multi-organ system dysfunction. HLH diagnostic criteria can be met with either a molecular diagnosis consistent with HLH, or you can meet 5 of 8 diagnostic criteria, which consist of clinical criteria, laboratory criteria, or histopathologic criteria. Here, we present to you a case of a 57-year-old Hispanic male who denied any past medical history, who presented to the emergency department complaining of fever, chills, malaise, diaphoresis, and dizziness for 1 week. He reported 1 episode of a spontaneous nosebleed a few days prior to admission, and a non-pruritic waxing and waning rash that started 5 months ago on his lower extremities and progressively involved his anterior and posterior torso. He denied loss of appetite, weight loss, sick contact, sore throat, cough, shortness of breath, or any other symptoms. His initial vital signs revealed a temperature of 38.4 degrees Celsius, a blood pressure of 148/95, a heart rate of 90, respiratory rate of 16, and an O2 saturation of 99% on room air. His physical exam was notable for diaphoresis, tachycardia, diffuse erythematous blanching maculopapular rash on anterior and posterior torso and bilateral upper extremities, and an erythematous circular non-blanching maculopapular rash on bilateral shins. His initial labs were significant for elevation of his liver function tests, platelet count of 24,000, and monocytosis of 20%. His CT abdomen and pelvis revealed hepatosplenomegaly. The patient received fluids, Tylenol, blood cultures were drawn, and he was empirically started on antibiotics. Thrombotic microangiopathies were ruled out by peripheral smear. Flow cytometry revealed immunophenotypic evidence of a minor immature cell comprising approximately 1%, suspicious for myeloblast. His bone marrow biopsy demonstrated a marked hypercellular marrow with left-shifted neutrophilic myelopoiesis, megakaryopoiesis, and an increase in polyclonal plasma cells. Encoded RNA by in situ hybridization stains revealed EBV-positive infected cells, although no hemophagocytosis was morphologically identified. Pathology suggested HLH should be ruled out. The patient met diagnostic criteria with 5 of 8 findings for HLH. The patient was initiated on corticosteroids and transferred to a cancer center for chemotherapy and unfortunately expired shortly after. In conclusion, accurate and prompt diagnosis of HLH is a clinical challenge due to the relative rarity of the condition, nonspecific findings, and the variability in presentation. HLH and severe sepsis can have significant overlaps in symptoms and presentation. Patient met diagnostic criteria with 5 of 8 findings for HLH based on HLH 2004 trial, with fever greater than 38.5 degrees Celsius, splenomegaly, hypertriglyceridemia greater than 265 milligrams per deciliter, hypofibrinogenemia with less than 150 milligrams per deciliter, ferritin greater than 500 nanograms per milliliter, and soluble IL-2 receptor alpha 2 standard deviations above age-adjusted values. Our case highlights that in a patient with unexplained fever, rash, and altered liver function tests, viral etiology leading to secondary HLH needs to be considered. Due to a high mortality rate, early diagnosis and treatment initiation is imperative to prevent multi-organ failure. Thank you.